All right, welcome everyone. So this is our third seminar for the Spring Birth series. Before we start, I just wanted to remind everyone that the talk will be recorded, and the slide and the video, the recording will be available to the registered participant after, like, in a couple of days. So today we have Andrew Geronimo from Penn State. He's an assistant professor at the Department of Neurosurgery. And his general research interests are along the line of developing technology, care, and well-being for individuals with neurological diseases. And he's going to talk about some of the joint work around COVID-19 today. Andrew, I'm going to stop sharing my screen and allow you to share your screen. So without further ado, take it away.
Okay, glad to do so, and thank you. Can everyone see my presentation?
Yes.
Fully. Okay, let me minimize you guys, or move you at least. Yeah, I'm going to be talking about some work that's a few years old now, but it was a really interesting project that a group of researchers across University Park and Hershey took on to track and predict the early COVID-19 pandemic across the African continent. So this was a result of a project that was ongoing in the lab of Dr. Stephen Schiff, who's one of the collaborators on this project, looking at infant mortality and hydrocephalus in Uganda. And he was using a modeling, mapping, and prediction structure to be able to track when, in what regions of the country children would be at risk for developing hydrocephalus and developing policy based on that. So let me see if I can move forward. So what I'll talk about today is kind of our motivation for doing this tracking of COVID-19, which is quite out of date now, but circa late 2020, this was an accurate and up-to-date model of the COVID-19 epidemic in that continent. So what we wanted to do is to be able to distinguish cases arising from within and between countries, and incorporate factors which we thought might have an effect on COVID-19 transmission, such as climate, economic status, and policy decisions by government. Our results at that time showed how testing capacity and social and health policy contribute to the dynamics of cases in an individual country. As a result of our modeling, we were able to develop short-term prediction forecasts, which were actually, to my understanding, used by the National Planning Commission of the country of Uganda. So as I mentioned, this was based on the P3H project, for which Dr. Steve Schiff is the PI. My co-authors on this should be given much of the credit for the work. I'll do my best to explain the project as well as I can. It's a little intimidating, not coming from a purely biostatistics background. I will do my best. I'm glad to take any questions you might have, but I might not have the answers for you until I confer with colleagues. So interrupt me at any time if you do. So this started, when COVID started, we started thinking about how to provide some sort of service to our colleagues in Uganda by providing some sort of forecasting for them. And it kind of evolved from there to a continent-wide forecasting of COVID transmission. We wanted to perform 7-day forecasting of case counts. We wanted to know whether they were coming from domestic or within borders versus international borders. And we wanted to know the factors that were predictive of high versus low disease transmission. Some of the data that was accessible to us through publicly available data sets were the case counts, social and economic policy, as well as meteorological and climate variables, which we had used in our other project. Some data that was maybe available in the US, but inaccessible to us in most of the countries we were working with were relatively up-to-date testing data and information about mobility and social distancing, which in a country like the US might be gathered through resources like Apple or Google, through cell phone apps. So we opted to, we spent a lot of time working on an SIR model, which is a kind of a Markov process process model to simulate disease progression, fit parameters to that, but we ended up using a regression-based model for disease surveillance, which was developed by, or at least coined by Leonard Held and colleagues back in 2005. And this uses, in part, previous case counts from 1 or more days prior as a factor in predicting current case counts, as well as other variables, other parameters. So it's a simple autoregressive model, which has been expanded to be to include spatial information as well as temporal information from multiple sources. It's called the triple H4 model. This is the multivariate time series model that we used. It uses a combination of endemic and pandemic components, the pandemic components being the autoregressive component, which relies on previous case counts from prior days. The main formulation of the model is that we're predicting can you see my cursor? We're predicting case counts on day I or day T in country I from case counts in the days prior, which are distributed with a Poisson or negative binomial distribution, which we used here. And these, the mean parameter of this negative binomial distribution is governed by this equation, which has an endemic component and pandemic components, or a baseline value and values that change based on the autoregressive coefficients that we're using. These cases can arise from within the country, or they can arise from connections to other countries. So it's a fairly simple model, and it will allow us to be able to fit parameters to find out what these within country transmission coefficients are, what the between country transmission coefficients are, and what the endemic coefficients are. We utilized a formation of this model that used higher order distributed lags. So instead of using just T-1 days, we used T all the way up to 14, and we found which one was or I should say, tau, T- tau, up to 14 days to see which one optimized model fit. And this optimization was performed in reality through a package in R, but it uses a likelihood or quasi-likelihood maximization method for optimizing these parameters. This is the generic formulation. I'll get in the next slide or next 2 slides, I'll get into the specific implementation. But
Andrew, before you move forward, just to make sure that as a clarification, so in the previous slides, when you show that the formula for the mean, so the second and the third components are basically the case counts, right, within the country, and the ones that are coming from outside country.
Yes, this is case counts in country I from the T-1 day prior.
Right, yeah.
And this is the sum of the case counts from country, all the J countries, which are connected to country I through some weight matrix W.
Gotcha. My question was going to be the endemic component. What is that? How do you measure that? Is that an error, or is it a measurable component?
In part, it's a random effect, which is what we did in the actual formulation of the model. But and you'll see this in the next part, we used the population of the country as the main contributor to the endemic component. In fact, when we fit the model, which you might expect, we didn't see a very large endemic component. We were modeling from the disease from the onset in March to up to August of 2020. So we didn't expect a huge endemic component to be resolved, although we did model it. In previous formulations of this, such as in influenza, which is where this was developed, and in measles, where there's a seasonality and some endemic component, which is always present in the population, the endemic component becomes more important, I think. If we were to redo this model now, I think we would see a larger contribution of the endemic component as the disease cycles through the population.
Right, thank you.
So this is implemented in the surveillance package in R, which is what we use to build our model and generate our visualizations that I'm going to show you in this talk. So for our formulation, we used the same conceptual model where over the past D days, we've got cases YT minus D through YT. And given those cases that we observe in these different countries, Our cases today are distributed as a negative binomial with a mean mu IT, which is the combination of endemic and pandemic components, kind of what I just described there. So the endemic component is really just a function, it's a random variable and of the log of the population. And then the pandemic components are where we've included more factors that we're interested in resolving the effect of. So sociodemographic variables, including policy, HDI, as well as climate variables, stringency of, I guess that's policy, but also certain geographic aspects as well. I'll go into each of these components very briefly, but here's our endemic coefficient right here, which the log of that is fit to this equation, where it's really just dependent on population. What I'm calling the within country component of our pandemic component is the parameter that's being fit to this component is our lambda. And this varies with time and country, and it's a function of population, human development index, it's the country's landlocked status, a stringency index, which is S, testing policy, as well as climate variables of temperature, rainfall, and humidity. We included these because the project that we've been working on, which was a specific type of microbe leading to hydrocephalus, was in fact very much a function of these variables. So we had these variables, and it wasn't clear at this point whether these climate variables would affect the transmission of COVID. So they were included in our model as well. The between country components was made up of many of the same variables, except we omitted temperature, climate variables. So we thought it reasonable that the stringency policy of other countries might affect transmission in the country of interest. So the border crossings in Kenya might affect the case transmission in Uganda, which is why we kept the testing and stringency components in the neighbor or the between country component of the pandemic model. So what this comes down to is fitting a number of parameters, including all of these Greek letters for the individual components of our endemic and pandemic components, finding what the optimal lag D is. So how many days of case data should we be using to determine the best fit to the model? And then I think we had to fit the overdispersion parameter as well, which is this second parameter to the negative binomial. But I could talk about that more or less. So that's one thing I might not be able to converse too easily about, but we'll see. So here's some of our data, and I want to show you the data we were working with because it might spur some conversation about what's appropriate for this model set and what's maybe not appropriate. But as you can imagine, Africa is an extremely diverse continent for many reasons, and reporting of case data and other data is one of those. So we had good examples of case data where it was reported on a daily basis and the numbers didn't change drastically from day to day, as in the case of Algeria. Others reported cases on a weekly basis where we had to deal with case counts coming in every 7 days or even less frequently. And then in other countries, they stopped reporting at some point into the pandemic where it became overwhelming, or they just decided to not release that data to the public anymore. So you can kind of see the different trajectories of case loads in Northern Africa versus Southern Africa, and then everywhere in between, and kind of the variety of data that we were working with, at least for case counts. And this was taken from something we all got very used to during the early pandemic, which was at Johns Hopkins Center for System Science and Engineering, where they had either countrywide case counts or statewide or countywide in the case of the United States. Other variables that we used, we took from the United Nations, either the Department of Economic and Social Affairs or the Statistics Division. We got population of each country, the Human Development Index, as well as the landlocked status or access to the coast. The Human Development Index represents broadly the status of education, the economy and healthcare in the country. And we know from looking at some of these correlations here that I've got on the right, that HDI in Africa corresponds to the median age of the population. So those with extremely young populations tend to have a lower HDI. So we didn't include age for that reason in the model because it was highly correlated with HDI. I will mention that for this model where we didn't have spatial connectivity between countries, as in Madagascar and other island nations off the coast of Africa, they weren't included in the model. So they, because we couldn't have using the way that we connected the countries, they weren't connected in any way. So the way that we connected countries is through this adjacency order. So this WIJ defines the closeness of these countries, how much of an effect case counts on country J should have on country I. And it makes sense to have countries that are well connected to have high spatial connectivity. We define spatial connectivity using this inverse power law, where O is a path length. So Algeria is 1 away from Morocco, and maybe 2 or 3 away from Egypt, right? We counted it by country length. So there's a maximum adjacency of up to 9 in Africa. The farthest country away is 9 countries away from its other farthest. And therefore we can get this matrix WIJ, which was then normalized by rows in order to get the final connectivity matrix. This is the parameter I forgot. So this parameter, this decay parameter on the spatial connectivity was also fit as a part of the likelihood maximization procedure. Some of the variables that I worked with on the project were the climate variables, and this was temperature. And the way we computed temperature by country was we did it on each day. We took the population weighted temperature. So we had this 10-kilometer raster of temperature from the UK Met Service. And we used this population raster to get a population weighted average. As you can see, it has big effects in desert countries like Algeria, where people tend to live in the cooler parts of the country. Therefore, the weighted average is much cooler than the unweighted average. So this is just a plot I created to show to to Steve during one of our meetings because I thought it was interesting. But this is the weighted temperature that we're using in the model. This is for 1 day, and we're using like all of our other climate variables, we're using lagged temperature. So temperature from tau days before the day of interest. We found tau of 7 was a useful variable to use for temperature, rainfall, and humidity. Rainfall is shown in the next plot. Not much new to see here except the different colors, but we weighted rainfall by population as well as humidity. This was something we struggled with, quantifying the transmissibility of COVID in this population. Like I'd mentioned before, a lot of ways you can do this rely on cell phone data, whether that was with one of the earliest publications we read coming out of Science, where they looked at this Baidu mobility index and how it changed over the course of prior to and during and after lockdown. You can look at the data for the United States as well. If for Philadelphia County using Google's mobility data. This is really just one data set though. It uses Google Maps to find where people are, whether they're in a residential area, whether they're in the workplace, and how that changed over time from a baseline of, I believe, January 2020. So for our case, we didn't have cell phone data that was available to us, and we didn't have stratification of this data by social settings or age ranges or other ways that people would come in contact with each other. But we did have social policy data. And that policy data that we used was this Oxford COVID-19 government response tracker. Oxford School of Policy, no, I'm forgetting what school it was now, but they created a very detailed accounting of for every country what their social policies were for school closings and workplace closings and masking and closing of public transit, and limiting movement between regions. So this stringency index is a composite of many of those social distancing policies, whereas the testing policy is not a number of tests performed in a country on a given day or week, but whether they had no testing policy, whether they had very limited testing being done, or whether there was open testing to the public. So it was really a categorical variable from very closed, not very limited testing at a 0 to widely available and accessible testing at a 3. Here's an example of the stringency policies over the same time course. So from March to August of 2020, looking at how different countries had different responses according to this Oxford index. Many of them ramped up their lockdowns in April, and then became more lenient to more or less varying effect as we went towards August, I should say. The testing policy, of course, had less levels, so it didn't go from 0 to 100, it only went from 0 to 3, but testing policy was, of course, very much different between countries as well. Countries with lots of resources and who had a very active pandemic, like South Africa, ramped up their testing policy to make it more accessible, whereas others where it wasn't as dire maybe didn't have as strong of a testing policy. So the way we fit the model, we used we tested iteratively a number of models, and we judged them based on the AIC to determine model fit. The original model that we looked at was just the random intercepts to see if there was a mean value of the endemic pandemic components that fit the data well. And not surprisingly, when we added more variables, we saw that we got a better fit. For our final model, where we included all the parameters that I showed in the previous slides, we found that landlocked status, stringency, and testing both seem to carry a significant relative risk, whether it was high or low, for case counts in a specific country. We also had some, I would say, not very strong relationships between weather data, specifically temperature and humidity, but they did pan out in the end with the model that we utilized. So once we found our fixed effects model with the optimal AIC, we included random effects into the model. And according to our statistician, Claudio, who I showed at the beginning there, he was telling us for the reasons of including random effects, it's not possible to compute AIC for this combination or for this model formulation. So we had to choose a model with the lowest AIC based on its fixed effects only, and then go ahead and include the random effects. But this is the model we finally reported on. We could see that countries with a higher mean temperature tended to have a higher case count. Opposite is true for humidity. Kind of non-intuitively, countries who had a higher stringency policy tended to have a higher case count. And this makes sense if you think of the case counts as a kind of a result of a higher stringency policy. Those who needed to implement stronger social distancing measures probably had higher case counts to begin with. So we did see that these bolded effects, I don't know if the bold is clear, but these bolded effects to come out as those with significantly greater than one relative risk. We also, during this testing process where we were testing this our model 5, the fixed effects model, we tested a number of lags on our data. So which model, what was the lowest AIC, whether we used case data from only 1 or 2 days before, or if we used case data up to 7 to 14 days before. So we did test up to 14 days, and we found that 7 days of prior case data produced the lowest AIC, so we used this in our final model. We also tested a number of different kernels to use for our lagged weights on our case data. If you remember, that's the U parameter from the model above. I can go back to that now. It's this UD. the kernel associated with this, whether it was geometric or whether it was Poisson. We decided that Poisson was a more appropriate kernel to use for infectious data, case data like this, where we wouldn't expect someone to be very infectious the day after they maybe reported becoming infected, but would reach maximum infectiousness a few days after that. So some of the results of our model, excuse me, we wanted to see whether new cases were estimated to be coming from within a country or from other countries. I'm showing examples of 4 countries here where the observed case counts are the black dots. And then we've got orange, green, and blue components representing the internal cases in orange, the external cases in green, and then the endemic component, which is non-significant in all of these countries here. There's really no way for us to kind of validate this, but it gives us some idea of what we went to our colleagues in Uganda with, telling them, early on that, not a lot of the cases are coming from within the country, whereas as they opened up more of their borders and became and allowed more traffic to flow across the borders of the country, they started accumulating more cases from outside the country's borders. Countries or Uganda's big trading partners being Kenya and Tanzania. This shows the relative cumulative within country contributions. So countries that are indicated in very dark red, over the course of the pandemic, they had most of their cases arising from within the country, whereas those towards the yellow or the blue scale had a good proportion of their cases arising from other countries, according to our model. Of course, these are model outputs. The only data that is based on observation are the black dots for observed case counts. We were also interested in predicting case counts 7 days ahead, though. And you might think 7 days ahead is not very long. You kind of remember seeing all the graphs of predicting months and weeks out, and they never really turned out to be accurate. But this one, we decided to just predict 7 days out to kind of give an indication of whether we should expect a short-term increase or decrease. The observed reported cases are the dark black circles. We held out the data from the last week and predicted case counts in the last week. And it's given by the mean value, which is the open circles, as well as a 50 to 90%, 95% confidence interval in that case count that we expected in each country. We did this for each country, and as you can expect, for those where we had relatively little data, or where there was irregularity of data, we were really predicting towards the mean, right? We weren't expecting to predict each day as accurate as maybe we would for countries who reported high caseloads regularly, like Algeria, South Africa, Egypt. And it wasn't always the case that we predicted accurately on a daily basis. But for the most part, it tracked with the actual progression of cases. And I think I might have said something incorrectly here. I think these cases were left out of the model, these open circles. These are actual observed cases, but they were left out of the model. And what was predicted was the orange line and the orange shading as the mean and the 95% confidence interval. So the last thing I wanted to mention was that as part of this project, we also worked with a number of students, which was great because they were all shunned. They were, sent out of their labs, not able to work. And a lot of them worked on code and some of them even developed some nice products. Jake worked with me on developing a R-Shiny implementation of our results, where you could view observed covariates like reported cases or temperature on a country-wide basis, and then run the model that was described in the paper, give predictions. We also had an updated version of this model, which was regularly pulling data from the Met Service, data from Johns Hopkins, and updating it on a daily basis. That's no longer active, but it was really useful to be able to give something like that to our colleagues at the time. I think that's all I have. I'm glad to take questions. And I hope I can answer them.
Well, thanks, Andrew. Are there any questions for Andrew? I have a question about, again, based on the setup of the model that you guys used.
Sure.
There were some terms that says T minus D. Was that just the lag terms?
Yes. So whenever we saw things like stringency or testing, we didn't think the testing policy on that day was going to affect cases or the stringency on that day.
Yeah.
So we tested a number of lags, tau,
Okay.
For which we would lag weather data, stringency data, testing data. The tau we ended up using was 14 days, I think.
Okay.
Where we were interested in the weather data or the stringency data 14 days prior that we thought would be affecting cases today. So that was the tau that was
constant lag for all the features, right?
Yes.
Okay. Is that a flexibility to allow different lags if you want in the model, or does that make things?
No, I think it would be allowed. Full disclosure, the more complicated this model became, the more often we ran into convergence issues.
Yeah,
so we tried to keep the model as simple as we could, kind of regularly increasing the number of covariates that we thought might be important. And I guess we just didn't see the need to utilize different lags for different variables. But I could imagine why you would. Maybe stringency having a larger immediate effect over case counts than maybe rainfall data, which might result in a month's time higher breeding population of mosquitoes. And this is more in the case of other diseases other than COVID, but these are different lags and timescales you might think of.
Yep, thank you. Any other questions?
Yes, Angel, this is Mosok. I have a question.
Yes.
Like you have shown that like some country, they don't have all the data, right? So how do you deal with it?
Great question. And I didn't mention it here, but we reduced our country set down to 7 times 35 plus 5, about 40, right? And that's not all the countries in the continent. We eliminated countries because we couldn't connect them to the mainland. We also eliminated countries because they didn't report case data for whatever reason, or they didn't report stringency data. So we did unfortunately have to eliminate countries, and it's why in certain graphs, I guess I don't have it here, but I guess the graphs in gray here, or the colors in gray here, are countries that we were not able to analyze because they didn't have the required data. There was a little bit of interpolation done on things, right? Because we didn't always have case data for every day, and therefore there was some interpolation that wasn't done directly, but maybe indirectly, because we were using a 7-day lag on case counts. We were effectively kind of doing some sort of mean fitting or interpolation on that. But yes, missing data was a big piece of what we were constantly struggling with. In some of the cases, we decided to just forego analysis of that country's data if it was significant enough.
I see. Thank you.
Sure.
Any other questions?
I have a question. It's Shui Xing. Thank you, Andrew's wonderful speech. It's very interesting. Actually, I just a question about the stringency index. So, is this about the just stringency of the policy the government made, or this is a stringency degree the country implemented? So
Great point.
yeah.
Great point. It is policy. So it's the policy that's from either the highest level of government or in some iterations of the stringency index that was implemented by this group at the regional level for whether there was a specific state policy. But yes, it was based on some sort of linear combination of these 9 factors in green, where the factors were either there were no measures or they were progressively stricter measures on whether people were ordered to shelter in place, whether public transit was closed, and all the other things on this list. It was importantly not people's response to that or the adherence to it, or how much the enforcement of that. So it was purely policy.
Okay, thank you. It's very helpful. Another thing that I think maybe as a little thing, I noticed the testing, the testing and the effect of the stringency is opposite. So, but I'm not sure if a country, I mean, maybe to some extent, the testing is kind of correlated with policy, or maybe that's the reason why there's a just a intuitive result.
Yeah, unfortunately, I don't have a great answer for your last suggestion about how interrelated stringency and testing were. I remember there was a big discussion we had about separating these out, and we ended up separating them because we thought it was useful to include them separately in the model. But I don't have a great response for how related these were. You can kind of see on here that testing was a fairly static variable, and we really only saw differences in between countries, whereas there wasn't much movement within a single country for the most case. But again, a varied continent with lots of varying policies.
Yeah, thank you. Thank you very much. That's a very interesting topic. Thank you so much.
You're welcome.
All right, any other questions?
Andrew, thanks. That was a really great talk. I was wondering, you showed that map of the kind of within proportion. It looks like Botswana really sticks out there, and there are a few others. Can you talk a little bit about what you hypothesize is potentially which of those covariates is driving that potentially?
A great question. I think I had another slide which I might not have included. I don't know if we talked specifically about Botswana, but we had talked about, I'm not sure if this is Rwanda or Burundi here, but we had talked about this country that would also seem to see a high proportion of cases arising from outside its borders. And to be honest, I don't think we ever came up with an explanation for why that was. The benefit of this model is that we could look at what were the driving coefficients that produce that high lambda value, or that high contribution from within country, or I should say the high psi value, the high proportion of cases coming from outside the country versus within the country. But I don't have an answer for you, unfortunately.
Awesome, thanks.
Anyone else? Well, thank you, Andrew. And for the rest of you, as I said, you will have the slides and the recording sent to you if you're a registered participant. Thank you again, Andrew.
You're welcome. Thank you.
Yeah, have a good evening, everyone.
Bye.